I just want to thank everybody for joining our call today. This is a redo of the in-person investigator slash coordinator meeting that we had last weekend at the Improve Care Now community conference. If you were at the in-person meeting, thank you very much for coming. You don't need to attend this as well. This will also be recorded, so if there's anyone on your teams or at your sites that would like to review the slides at a later date, you'll have access to not only the slide deck, but the full recording of this. Why don't we get right into it, because I believe we have content that will take a full hour. So Josh, go ahead. So again, I'd like to thank all of you for your ongoing commitment to Combine, for spending an hour with us during lunchtime today. It is with your commitment we will answer the critically important clinical and research question about combination versus monotherapy for kids with Crohn's, and we will demonstrate the opportunity that we have as an Improve Care Now community to be a learning health system. And this is a theme that we spoke about a lot at the community conference. But essentially, the topic of this study is a topic that was a couple years ago from the community of clinicians and other local team members and patients and parents and researchers who all came together to recognize the importance of this treatment dilemma and to prioritize doing research in this area. It was a result of that research prioritization that enabled us to write the grant application that was ultimately funded. And now we as a community are pulling together to do that work. Once we've answered the question, again, it's we as a community that will pull together to disseminate what we learned from the study into our everyday practice and rapidly incorporate into clinical care the lessons learned from Combine. And hopefully, if this works, there will be a whole round of additional examples of the entire circle of research that we're able to do within our pediatric IBD and Improve Care Now community. Next slide. And so our agenda for the next hour or so, I'll let you all know where we're at with recruitment. I'll give you an overview of what's new in the study and what you can expect, and a couple of other changes that are underway. I will review where we're at in terms of study follow-up, data completeness, and what we're learning about safety thus far. A quick reminder about protected health information, or PHI. We'll do a update about the central IRB and some other regulatory matters. And we may have time for discussions at the end, depending on how quickly I talk. Next slide. In terms of site activation, we now have all 42 of our selected sites activated, which is awesome. Vanderbilt was our most recently activated site, and we expect great things from them, given their perseverance with the contracting issues that have been nagging at both sides of the equation. As of 11 days ago, we had 183 patients randomized. 33 of our 42 sites have recruited at least one patient. Congratulations to Choa, Emory, and Nicholas for each randomizing their first patient in August. And our leading sites so far are Cincinnati with 14 patients, Children's Hospital of the King's Daughter with 14 patients, and Stanford with 13 patients. And even these numbers are now out of date, which is great because we have more patients from some of these centers. Next slide. Collectively, as a combined study, we have approached over 1,400, we have pre-screened over 1,400 patients. and have approached 632 patients, which is almost 80% of those eligible. So that is a huge amount of work. We're learning that in aggregate, 30% of patients approached will consent, and we are continuing to see a lot of variability across sites in rates of patient identification and approach and consent. And Shahzad and Julie Massey continue to serve as a resource for all of us to learn from the variability across our sites and identify and distill and disseminate best practices. Next slide. Again, this slide here just shows that it really does take a village to do a large-scale clinical trial in pediatric Crohn's disease, which by NIH and FDA definitions is a rare disease. The fact that this graph here is getting wider and wider is telling us that more and more sites are actively recruiting patients, which is fantastic. Next slide. So who are the patients that we have recruited so far? Based on the first 173 patients, you can see here 69% are male, which makes sense. Pediatric Crohn's disease is predominantly a male condition, and I know that many providers and practices are a little bit reluctant to treat older teenage females with methotrexate due to the fact that methotrexate is a known teratogen and you can't get pregnant while taking it. So I think that that 69% male is about what you would expect. Mean age, 14 years. I didn't show this here, but the mean time from diagnosis is about a year. And so we are recruiting patients into this study relatively quickly after their diagnosis of Crohn's disease. And that sort of newly diagnosed patient population is historically not a population of patients that have enrolled in clinical trials. So we really are breaking new ground here, which is cool. You can see here the racial diversity, 77% white, 8% African American, and what's listed here as 10% unknown is probably a combination of unknown and other mixed race and things like that. In terms of which anti-TNFs our patients are taking, 72% starting on infliximab and 28% starting on adalimumab. Again, I think this makes sense with how many of us are practicing these days. Next slide. Again, this is just a reminder for me to let you know that the race and ethnicity information that for combined comes from the general improved and comes from the sort of initial enrollment tab of the Improved Care Now registry. And so when you're enrolling a patient in Combine, go to the Improved Care Now registry, go to that enrollment tab and make sure that the race and ethnicity is not only completed, but accurate as well. Next slide. This slide here shows our recruitment over time. The orange line is the patients, the total number of patients randomized by each shows where we were going to be at. You can see here there's quite a gap between to be and where we are. That orange line and make a arrow to the left to see where it intersects the green line, between 15 months behind where we were hoping to be. So not all behind the 8 ball slide. And so what do we have in power to mitigate these recruitment delays? Looking at the bottom of the slide in terms of what's next. For now, please continue to recruit patients at all of your centers and please do so of urgency. Many of you might look at your contracts, which say after you've recruited 15 patients, please ask permission before recruiting your 16th patient. Cincinnati Children's first site to ask you, yes, please do, are at sites that are to recruit your 15th patient. Yes, please do continue to recruit. You are approved to recruit as many patients as you possibly can, and we will be able to pay you for that. We will be extending our recruitment period a little bit longer. We're not quite sure how much longer at this point, at least several months, but hopefully longer than that. And for some patients, we may not have the full 2 years of follow-up before the project period ends. But I think if we're able to get 12 or 18 months of follow-up for those patients, it is certainly better than not recruiting them at all. Effectively, if the study ends before some patients have completed their 2 years of follow-up, it's effectively an early censoring procedure, which will be okay. Next slide. So I'd like to take just some time to recognize a lot of sites for their hard work and effort in Combine. And I'd like first to recognize Anne, who has gone through all of the recruitment data with a fine-tooth comb to help me identify some of the sites and individuals to specifically call out for really good performance. First off is the most patients randomized since our last community conference 6 months ago. Next slide. And this award goes to our Omaha site that has randomized patients between May and August. So really awesome recent activity. Next slide. Next is the site that has the most patients per month. Next. And this award goes to the Children's Hospital King's Daughter in Norfolk that has recruited a total of 14 patients, or 0.91 patients per month since the time of activation, which is really quite amazing. Next slide. Most patients randomized overall. Again, as we previously mentioned, CHKD is at the lead along with Cincinnati Children's. Keep going. And Stanford. Next slide. And this would actually be a really good time to recognize the outstanding efforts of KT Park in working closely with Aditi, the coordinator at Stanford. Many of you know that KT Park will be leaving Stanford later this week to take a job in industry. So thanks and goodbye to KT. Next is the most number of patients randomized on a single day. And you can click a few more slides. So Riley randomized 2 patients in February of 17. Keep going. Mass General, 2 patients in September of 17. Next slide. Omaha, 2 patients in August. Next slide. In terms of most number of patients randomized in a month, keep going. This one also goes to the Children's Hospital of the King's Daughter. Keep going. So there's no way to randomize a patient unless you start building what I call the wide end of the funnel, or pre-screening a lot of patients. And unless you have patients on your list and you're looking through their charts to determine eligibility, you'll never be able to recruit them. And so this slide shows here that Cincinnati and Riley have screened the largest numbers of patients. Next slide. After pre-screening, the next step is to approach and it takes a lot of work and a lot of time to patients and give them a fair and balanced understanding of what it means to participate in the study and the importance of the research question that we're answering. In terms of most numbers of patients is the lead, but Boston, Riley, Morris Wilmington, and universities done a large amount of lifting in approaching patients and educating them about he's approached Golisano of Virginia, Nebraska. Being in the patients approached, I know for sure we heard from the PI at Pediatric Specialists of Virginia that they may not be approaching enough patients, and they may be cherry picking patients that are most likely to say yes. And really, you never know until you try. And so we really do encourage sites to pre-screen as many patients as possible and approach as many patients as seem to be eligible. Really, we should give patients and families the opportunity to hear about the study and make a decision for themselves rather than assuming that we already know the answer. It's much more patient-centered to approach the patient and give the right educational messaging. Next slide. I'd like to recognize some sites that are new to the Combine team and sites with the first patient recruited since the last community conference. Lori, who has randomized patients. Next slide. Cardinal Glennon with 2 patients. Next slide. As previously mentioned, keep going. And Nicholas, as previously mentioned. Next slide. So of course, the success of a study is not only recruitment, but retention and follow-up, and Combine is a 2-year study. So the following sites have had a number of patients with long-term follow-up, here defined as no missed visits through visit 8 or week 78. Next slide. And so hats off to Riley with 4 patients in this category. Keep going. Nemours Wilmington with 2 patients in the category. Keep going. And UNC with 2 patients in this category. Keep going. Oh, and Nemours Jacksonville as well. Next. Perfect attendance at the at all PI meetings with next and you guys are just thrilled to join, so that is awesome. Keep going. And in terms of attending the last 4 of the PI coordinator meetings, we can add to this list MGH and Nationwide. So again, thank you all. Switching gears away from recruitment and recognition, I've got a couple of sort of a potpourri basket of announcements of things that are new, different, and hopefully improved with Combine. Next slide. And this is just a reminder to go to the SharePoint site for the latest of all of the tools and documents. I hope you all know where to find the SharePoint site. The address is included in all of our Combine newsletters. If you haven't been to the SharePoint site yet, please do get in touch with either Josh or Anne and let them talk you through how to log on. This really is an important repository. Not only can you find the latest version of everything, and not only does this help avoid version control issues, but it is also a secure place where your teams can upload documents that our central team and monitoring staff are able to view. So this is what the SharePoint site looks like and highlights the fact that there are new items in the coordinator tools and forms folder, the case report form folder, and the manuals and procedures folders. Next slide. You can show here, or you can see here on the right is the date that each of these folders or items were updated. and I've highlighted 3 items to call out. The first one is how to upload documents to the Combine SharePoint site in a secure fashion so that your teams can share documents with our central site. The MOP was, the Manual of Procedures was updated earlier this summer, as was the Combine Data Entry Users Manual. Next slide. On the SharePoint site, I just wanted to plug the Combine scheduling tool, which is a Excel-based document that I really do encourage all of you to use. For each patient that you randomize in Combine, you can put in their Combine ID and their randomization date on the left-hand column, and the rest will be pre-populated. Certain things of interest in the right, if you want to know for each participant, what is their current study day as of today, that will pre-populate, or what is study week as of today. And our outcomes tied, or many of our Combine procedures or visits, they're tied to the study week that patient is at. For example, we know that patients who start the study on steroids need to have steroid discontinued by week 16. And so we've gone, Jeff, you can maybe highlight where the first of the primary endpoint checks. You can see here what that week 16 date is, so that you know if the patient is still on steroids, is today's date before or after that week 16 date. If today's date is after that week 16 date and the patient is still on steroids, then they have failed to discontinue steroids by week 16 and have met one of the Combined primary outcomes. So I hope that this Excel-based tool is really helpful to all of you in tracking patients over time, understanding when they're due for their visits or overdue for their visits, and when to assess for various outcomes that are tied to a particular study week since randomization. Next slide. Josh, do you know how to do the next slide?
Sorry, having a little technical issues here.
No worries. It's a pretty cool red arrow, though. What if you push your down on the keyboard? Nope. All right, as Josh is trying to navigate to the next slide, I also wanted to make you aware of a slide deck that you all can use that was created as part of our engagement work for Combine, and is really, it's called Clinical Research 101. We did this in collaboration between our Combine team, particularly our Combine parents, as well as Improved Care in Began and the Crohn's and Colitis Foundation. Dr. David Wall, who is the parent of a patient with Crohn's disease, and I put together a slide deck. You all can download those slides and at any educational activities or events that you do locally at your centers that really sort of through what is research and the importance of clinical research in pediatric IBD, a little bit about different types of clinical research, whether it's a cohort study or a trial. If it's a trial, a little bit about the purpose of randomization, the purpose of placebos and controlled study designs and masked study designs and whatnot. And for those of you who want to direct engaged and activated patients to a pre-recorded video, you can do that as well, and that video is posted on the clinical trial community hosted by the Crohn's and Colitis Foundation. So I encourage you to download the slide sets and use them at your own sites for local education activities. But if not, you can also point parents to the pre-recorded webinars. Next slide. I do want to call your attention to a number of case report form changes that are currently live. You can find the PDF version of the updated case report forms on SharePoint. And again, the electronic version is already live in the database. So you'll note that the minor modifications to the screening visits to broaden the eligibility to correspond with the protocol amendment that we spoke to you about in the spring. We specifically put in wording that we treat biosimilars the same as originators for the purpose of Combine. The exclusion criteria about the body mass index used to be greater than or equal to 95 percentile for age and gender, and we've expanded that to greater than the 98th percentile for age and gender. As you know, we also have expanded our visit windows, and so the online CRFs and registry has these expanded visit windows listed as well. Next slide. For the dose change, continue we a little bit dose is for with higher dose because you meet the endpoint. We'll have you indicate which outcome or outcomes the patient met from our combined study outcomes here. And in particular, we're going to be looking through the data that you enter into the database to make sure that there is agreement between the outcomes listed here and whether those outcomes are supported by data in the database. For example, if you indicate the patient failed to achieve remission by the week 26 visit, we would want to see in the data you have visits after the week 26 visit where the patient is not in remission according to the DAI. Our teacher is going to be looking at all of this. If there's a discrepancy to clarify. All right, other changes that should be on week if early with view and a selection of provider review in not torture for providers who data enter, please do so. Every time a completes a investigator should an email form completed, please log on and the provider review should not only include that itself, but also that the was done and relevant. The concomitant medication forms were updated, the forms were updated, the colonoscopy form, and whatever else is the changes in status or information about a patient. And aside serves as a script to our pharmacy that it's okay to start the patient on study medications or continue the patient on study medications. We have 3 different versions of the provider review. The screening version essentially is a double check, so the provider can confirm that the inclusion-exclusion criteria are met, and it's good to go ahead and randomize the patient. The review at designated study visits is a primary that patient has achieved outcomes and it is reasonable and safe and appropriate for them to continue on study drugs. And then the additional visit is a double check to ensure that primary endpoints were met. And whatever else is the changes in status or information about a patient. And aside serves as a script to our pharmacy that it's okay to start the patient on study medications or continue the patient on study medications. We have 3 different versions of the provider review. The screening version essentially is a double check, so the provider can confirm that the inclusion-exclusion criteria are met, and it's good to go ahead and randomize the patient. The review at designated study visits is a primary met, or excuse me, the primary endpoints were not yet met. You'll note that based on some early feedback, we stopped asking for a provider review in patients who have already met an outcome and have already discontinued study drug because it's not necessary. The patient's off drug. We don't need this to serve as a prescription anymore. Next slide. We have recently shortened the provider, or later this week we'll be doing provider review for additional study visits. Rather than asking a number of questions about the patient has or has, it's going to be much more streamlined, and you'll be given two choices. The first, patient has not yet met a combined study outcome and will continue to receive methotrexate placebo protocol, or the patient has met a combined endpoint and will need to discontinue treatment. And if you're answering yes to that, then there should also be a dose change or discontinuation form that is to be completed. When you are doing that provider review, has or has not yet met, again, that Excel document that I showed you earlier really it helps for the coordinator and PI to look at that Excel document, look at the EHR together, and just sort of quickly model through that based on whatever study day or week the patient happens to be at the time the visit was completed. Next slide. I do want to talk a little bit about Combine and the Improved Care Now registry and some changes that we'll make to help with that. Generally speaking, every Combine visit should have an accompanying registry visit on the same date. Expect that you're doing your Combine usually in the context of providing rare as a entity, enter all of our routine visits into the Improved Care Now registry. For Combine, we take a lot of that important data directly from the registry rather than have you enter the same data in both the registry and the Combine forms. So we really did try to make your life easy by not having you enter the same data twice. But what that means is that we really do need to have a registry visit entered every time there's a Combine. Only visit without a full clinic visit, and so there may not actually be a registry visit to sort of dovetail with that Combine visit. Maybe the coordinator, patient, and provider saw a patient with infusion. That's a solution, which I'll in a little bit. I also want to just sort of mention every registry also have a Combine visit and minimum more for that. And often if like a that but it's just not appropriate to enter a registry when a patient really will not seen that. We've combined capture this data. It just now registry. Next slide. So that complement collects the data that is usually collected through the ICN registry, the height assessment, P, hematocrit, sed-rate, albumin, anti-TNF troubles, and anti-TNF antibodies, and this retroactively. So as it's live, you can go back and enter this for prior combined visits, which just for and next slide. And so that's like yes of the if already the history second go on to the mental form and put it in physician global assessment. I'm going to update you a little bit on how and the next couple slides, a reminder, by really expect you to know within care feasible. We understand that might be feasible, and where routine care may sometimes be more frequent than what we've specified in the protocol. Next slide. And so the next few slides of the key activities, all included in the protocol and middle of summarized in table form, which you would nearly do when you see patients in clinic. Assess their clinical status, see if they've met any endpoints, see if they're having any potential adverse events or side effects, and check the labs that are typically checked for safety and treatment response. None of these procedures need to be done by combined staff. They can be done by the treating clinical teams. Sometimes it's helpful for the study PI or coordinator to coach providers in what tests to order or how to direct a appropriate history. And then there's other combined activities that are really done just for the purpose of the study and go beyond clinical care. That's entering data into the registry, signing off a provider review, discontinuation form as needed, collecting patient outcomes or study labs or whatnot. All of these combined activities do need to be done by designated study staff. Next slide. This slide here is just a reminder of the primary endpoints, and if you all are able to do anything super well during follow-up, it's making sure that we know which patients meet which endpoints on which dates. Next slide. And this is a reminder of what those primary endpoints are. I'm not going to go over it in detail. It is in your protocol. Next slide. So how are we doing and where are we at in terms of combined follow-up? Of the first 173 patients randomized, 75% are still active in follow-up and taking study drug. 18% are active and in follow-up and are no longer taking study drug. Either they've met a primary endpoint and stopped medication, or for some reason decided independently that they're going to stop medication. We have who withdrew early, even before their first drug was shipped. We have 3% of the started on study medication or had reasons of withdrawing. Medication do be following those patients as the protocol would specify. Withdrawing from the study means I really don't want to have any more follow-up at stopping drug use. Next. Here shows the visit completed based on the date of randomization. And again, for most of these visits, 20% of patients might skip one visit, but we'll get them at the next visit. And so in the end of the day, this all works out okay. We really have not had any patients that we don't have analyzable data. As a gap between visits, we have to instruct the pharmacy to stop sending study medication to patients just as a safety precaution. So if you skip one visit, it's okay. If you skip 2 visits, then supplies, which does become 170. Doing the completion. And the forms, and so the launch screening and filter. This is currently listed as a next slide. PROs, again, you all have been in touch with Jen Clegg at CHOP, who has been helping us track and compile the PRO collection. And as shown here, we're doing a pretty good job with that. Please do continue to send PROs to Jen Clegg shortly after they're collected. If you send them to her immediately upon collection, you'll save yourself and her time later on when she's trying to reconcile which ones she has. So please do send them to this email shown here. Next slide. A little bit about biosamples as well. In total, we've received 11 biosamples at our biobank. And again, that first biosample is done at either visit 3 or visit 4. The second biosample is collected towards the end of follow-up. We have not had patients who have reached this time point yet, so have not received any of those later biosamples. But having received 111 biosamples so far is great. Next slide. This is just a reminder that when you do send a biosample to us, complete the research lab section of the Combine database so that we are able to track this effectively. Next slide. We did some quality control testing for the samples that we have received at the central lab. We sent 20 samples to Grifols for quality control of anti-TNF level and antibody measurement. This includes samples from 18 different sites. And the really good news is that assays were able to be run on all 20 samples. All of the serum that we sent them passed their quality control checks. 13 patients were taking infliximab and 7 were taking adalimumab. All but one of the infliximab patients had detectable, measurable trough levels. And that one patient that did not have a detectable trough level had a positive antibody. None of the other patients had a positive antibody. So this makes clinical sense. Usually there's an inverse correlation between the presence of antibody and detectable trough levels. And so all 13 infliximab levels sort of checked out as one would expect. And we found the exact same pattern with all of the adalimumab levels. And so the samples we're getting are meeting all the quality control checks that we had hoped for. Next slide. I don't think Phil Minar is on the line, so we're going to skip over these. They will be part of your slide deck, and it's just a reminder of the by Dr. Minar and his team at Cincinnati Children's Hospital. At least all the coordinators on the call know that we send some blood to the UNC Biobank and others directly to Cincinnati Children's Hospital. And the next couple slides are an overview of what Dr. Minar's team is doing. So I'm going to skip over this. Over this. Of them were viable or usable for his assays, and some of the ones that were shipped on Monday and hung out over the weekends sort of didn't pass their quality control test. Just a couple of things that his lab team wanted me to recommend. Sometimes shipments were sent with the ice packs outside of the insulated pouches. Obviously, that's not going to keep the sample cold. And sometimes the ice packs are and they're no longer cold, or the packages come without an ice pack inserted. So again, for each of the sites, you need to put the ice packs in your freezer before you send them, load them into the shipping containers cold, and make sure that they are on the inside of the insulated pouch rather than outside. But thanks again for all of your efforts in collecting biosamples. We know that it is a timely, time-intensive process. Next slide. These are the adverse events that you all have. This slide highlights the adverse events reported in greater than 2% of the population. Most of them have been of other, really is no consistent pattern. But aside from that, the more common ones are shown here: infection, abdominal discomfort, nausea, vomiting, headache, and very few patients with elevated or comorbidity. No, but thank you all for being diligent in reporting them. New or anything that we wouldn't expect based on our several decade experience using methotrexate in FTD. Next slide. I also need to remind you of the SAEs that have been reported, and I've summarized them here. 4 for abdominal pain or discomfort, sometimes with constipation. 3 with nausea or vomiting, 2 infusion reactions. 2 with suicidal ideation or intestinal ingestion, a tenosynovitis, a bowel microperf, an ileocystectomy, 1 really bad headache, evidently. As a reminder, AEs or SAEs that are related to the progression of underlying Crohn's disease don't need to be reported separately, especially for many of these. We'll get them as when the short pediatric Crohn's disease activity index is elevated for patients that you see in the outpatient setting, or we'll get them as hospitalization reports through the registry. You're free to report them as AEs or SAEs if you want. That's totally at the discretion of the site investigator and whatever you're most comfortable with. Next slide. I'm going to skip over these. They're included as your reference, and it just details the 15 reported SAEs. So skip this slide, and the next one, and the next one. Medical record or dates, anything that has and so if you're sending any information that has the date that a test was done, or a date that an AE started or anything like that, it is PHI and it needs to be sent securely by email. Next slide. And so work with your institution to figure out how to send secure emails. At our site at UNC, we have to put the word secure in parentheses in the subject line, and then the recipient will get something that says you've received a encrypted message from, and it'll take you to another portal where you've got to put in a username and password in order to open up that secure message. Cincinnati Children's uses something called Zix, which is shown on the bottom of the slide. If you are sending PHI by email, that's okay. Just please do encrypt it. Otherwise, it becomes a protocol deviation, and it's a whole bunch of paperwork for all involved. Next slide. And then the last couple of slides have to do with some regulatory updates. I don't know if Stephanie Sullivan is on the call. If she is, Stephanie can go through these. If not, I will. Josh, is Stephanie on?
I do not see her.
Okay, next slide. So there's a change in policy at the central IRB that is going to streamline things a little bit regarding when you all add or change staff at your sites. So the central IRB will no longer require an IRB amendment every time you change staff at your sites, but rather the IRB will acknowledge staff listings once per year at the time of continuing review. And by submitting the staff listing to Cincinnati Children's, essentially that means that the site PI is confirming that the study staff have current credentials and they are stored somewhere locally, and that the study staff have required all of the trainings and have sent those trainings to Cincinnati Children's, sent documentation of the trainings to Cincinnati Children's. Next slide. Cincinnati Children's regulatory staff, particularly Stephanie, are no longer going to collect, review, and store all of the site credentials that you all have. So that includes signed and dated CVs, city and GCP training certificates, proof of medical licensure for investigators, etc. Rather, the sites will just submit amendments once a year to cover all of this. Cincinnati Children's will continue to collect and store credentials for the site PI only in the trial master file. And so what this means, again, is that the site PI and the site itself must continue to store all of these things locally and be prepared at times for an audit from the central or your local IRB. So sites are not off the hook for collecting all of these documents, but sites are off the hook in sending them to Cincinnati Children's. Next slide. So the site PI in all of this, I really do need to emphasize, is in charge with making sure that that site maintains current credentials in a regulatory binder. For the entire duration of the study, they should be reviewed regularly and updated as they expire. So for example, my city training just expired and I had to renew that training and send my coordinator a copy of that so that she could add it to our local combined file. The central IRB or local IRB can request these for an audit at any time, and similarly, the study monitor may request them. So don't collect them in response to an audit, collect them in real time as part of your site's practice. Again, it is your responsibility to ensure that study staff are compliant with your institutional regulations before starting to do human subjects research. When you have a new coordinator, make sure they're city and GCP trained before they start working on the project. The study PI must ensure that all combined specific training is completed prior to working on the project as well. And the site PI responsibilities in all of this really haven't changed at all. The only change is streamlining what it is that each site needs to submit to Cincinnati Children's. Next slide. Switching gears a little bit, we are now in the throes of IRB continuing review this fall. Your sites will be hearing from Stephanie Sullivan later this week or next week. Please review her email carefully and respond to her promptly. She is on a very tight timeline. We're asking a 1-week turnaround to review the email that she sends you about continuing review and respond to that. She tells me that it will really take only 10 to 15 minutes of time at your site, and here's what you're going to be asked to do. Next slide. There'll be a questionnaire about your site's progress over the last year, particularly about patients screened and recruited and followed and all of that sort of stuff. We are going to pre-populate that table for you. Let us know if it's incorrect, but otherwise you should be good to go with what we pre-populate for your site if all looks good. Send the last de-identified consent form over to us, and the last one as of September 7th. So if you recruited a patient today, don't send that one. Send the one on the patient that you recruited up to, but not before, but not after September 7th. You want to block out the name of the patient and parent, but don't block out the name of the staff that obtained the consent. You probably want to use a Post-it note to block out the name rather than a Sharpie, because we don't want you to X out the name of the patient or parent on your original source documentation, or that would be a really big problem. Again, with annual review, with the time, update your study staff in Excel doing that. And upon annual review, we all update our deviation logs, which are a running log of all of our deviations from the start of study to the present time. So it's not what's new in the last year. You can just update the one that was sent to us last year with anything new that has happened since then. Next slide. And I think that is my last slide. So we are about out of time, but if there are any last minute questions, please raise your hand and type it into the chat box, or feel free to send a note to Josh or Anne or myself at any point in time, and certainly do review all of the materials that are on SharePoint, because I think a lot of the questions that sites have are not new to us anymore, and we have answers to many of them on SharePoint. So I'll stop here, and again, Josh, if there's any questions, please let me know.
If you have a question, please raise your hand or type in the chat. And I'll...
All right, well, I guess we can break. It is right at 1 o'clock. Thank you all for attending the call. And as a reminder, it will be recorded. So for staff or PIs at your site that were not able to make this, or the in-person, please direct them to the recording when it's posted on SharePoint, and the slides will be posted as well. Thanks again.
Thank you all. Have a good day. Bye.